Greetings and a warm welcome to all the dignitaries present here. I am Shwastika from Team Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet is India's most trusted and widely used digital platform offering a multitude of imaging services exclusively for the doctors. Clarnet is delighted to be chosen as a digital partner for this event, jointly organized by Karnataka chapter of IACTA, Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anesthesiologists, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and Global Healthcare Foundation. So today's focus would be tricuspid and pulmonary valves. Let's begin today's session with welcome video. So, thank you so much for your patience hearing. And now I would like to invite Dr. Muralidhar sir to take over. Over to you, sir. Let's wait for a few more minutes as Dr. Murali has left out for a minute. So let's wait for a few minutes and he will be joining very soon.
Got
Yes, as
switched off.
Dr. Murali has joined. Over to you, sir.
Thank you so much. It's my great pleasure to welcome you for this Sunday edition of the breakfast session, which is being conducted under the Karnataka chapter of IACTA, Indian Association of Cardiothoracic Surgeons, Indian College of Anesthesiology, Global Heart Care Foundation, Global Intensive Care, and the International Society for Cardiac Ultrasound. I'm really grateful to these organizations for continued support and patronage to this educational activity. Today, we'll be dealing with the echocardiographic evaluation of tricuspid and pulmonary valves. And we have three faculty from India who are well known in cardiac anesthesia and echocardiography. Dr. Rachna Wadhwa from Delhi, Dr. Divya Gopal, and Dr. Durga from Bangalore. I'm grateful that they are spending their valuable time with us today, and we are looking forward to their presentation. Before I hand it over to the moderators, I would like to request our participants to keep the mics off and post your questions on the chat box. Comments may also be posted. And if you would like, you can unmute yourself during the question answer session and speak directly into the meeting. because the IACTA meeting is there in Vizag next week, there will be no session on the 1st March this year, and then we will again meet on the 8th March. With these few announcements, I would like to request Dr. Divya Gopal from Jaydeva and Dr. Durga from Narayana to take over and do this session. Thank you so much.
Thank you, sir. Thank you for the warm welcome. This is Dr. Durga. Shall I?
Yeah,
Yes.
please.
So, thank you. It gives me immense pleasure to introduce our esteemed speaker for the session, Dr. Rachna Wadhwa, who is a professor at GB Pant Hospital, Delhi, and she has numerous publications to her credit. She has her areas of interest being TE, echo, perioperative management in cardiac patients, and then she has more than 100 plus presentations and lectures in state and national level conferences. So she'll be speaking on tricuspid valve and pulmonary valve echocardiography today. So please join me in welcoming Dr. Rachna Wadhwa from GB Pant. Welcome, Dr. Rachna. Stage is yours.
Thank you, Dr. Divya, for this kind introduction. Thank you so much. Is my screen visible?
Yes, ma'am.
Okay. So shall I begin, sir, with your kind permission? Good morning, all. So today I will be discussing about the transesophageal as well as bit of transthoracic evaluation of tricuspid valve and pulmonary valve. To begin with, first I'll be dealing with the tricuspid valve, basically TEE. No conflict of interest and no financial implications. So to begin with, first we'll go through the anatomy, the multiple views of transesophageal assessment. First, the two-dimensional assessment, and now the how to go for the 3D acquisition. So three-dimensional echocardiography is now what is being done for the tricuspid valve, just because you know that it is independent predictor of death, and n number of times people do address left side of heart, but tricuspid valve was being abandoned, but now it is no more being abandoned, and now circulation gave this review of pathology, imaging, and current treatment in 2024, and it gives us actually this is a very good review, and if anyone wants to have real insight into the tricuspid valve innovations, this is one of the good articles to go through. It is no longer the forgotten valve, and in this new era of cardiovascular innovations as well as interventions, now TEER has come a long way, where we know the pathology and how to manage. So now three-dimensional echo is being used for transcatheter edge-to-edge repair in our cath labs, and we have got an important role to play in guiding these repairs as well as replacements. So this Journal of Cardiology gave us this came in 2025, where they have given all the details of the current landscape, the future perspectives of transcatheter tricuspid valve interventions. To begin with anatomy, see, so we've got this pulmonary valve which is placed anteriorly. This is the aortic valve. These two are semilunar valves. This is tricuspid and this is mitral. So this is interatrial septum. So this is septal leaflet. This is anterior and this is posterior leaflet. This anterior septal related to the aorta. I think this image is what we need for making our NFAS views. So we should know this relation. Being this pulmonary valve, the farthest. So if I do the transthoracic imaging, this I can image pulmonary valve better. If I'm doing a transesophageal, then these will be better as compared to these anterior structure. So tricuspid valve anatomically, this is largest and this is most apically placed. Okay. And what is the area ranges from 7 to 9 centimeters square. It is D-shaped ellipsoid. It is not a planar structure. And there is a very low pressure gradient, like less than 2 millimeters of mercury. And even if the gradient is more than 2, it is significant. Structurally, it consists of annulus, leaflets, papillary muscles, and chordae tendina, like all other valves. So there are 3 leaflets, septal leaflet. If I see it, this is posterior leaflet and this is anterior leaflet. There are 3 commissures, which are basically indentations. There are 3 papillary muscles. The chordae tendinae arises from these papillary muscles to the leaflets. And there are multiple caudal arrangements. Because of this multiple caudal attachments, which are like crisscross. So this explains our RV dysfunction whenever there is severe TR. So the 3 papillary muscles are anterior, posterior, and septal. Anterior, posterior are the largest, septal is the smallest. And what is important is that anterior papillary muscle, it connects the septal muscle via the septomarginal tubercular, that is moderator band. This is how, in pediatrics, we do differentiate RV from LV. RV has got this moderator band. Now, what is the importance of this? It not only aids in deflecting the bloodstream from inflow to outflow, it carries a major twig of right bundle branch. So knowing this is very important. Surgically, the patient, may go into block once the surgeons interfere with this. So as I told you, this annulus is saddle shape. What do we mean by saddle shape? That it has got high points as well as low points. The normal annulus is 2.28 millimeters plus minus 5 millimeters. It is less fibrous than other annulus. What is important is that this measurement of annulus should be done in almost all the patients. See, if this annulus is more than 4, means the annulus is dilated. Normally, it is saddle-shaped. But if suppose there is RV dilatation, this becomes planar a bit. So there are high points and there are low points, and they may change with the right ventricular dilatation. So this is the normal annulus shape, which is saddle shaped. But after the annular dilatation, there is expansion at the RV free wall, and instead of the saddle, it becomes a bit more planar. This is something which is the most important, characteristic of knowing the tricuspid valve anatomy. So we've got septal leaflet, we've got anterior, we've got posterior leaflet. So there is one triangle known as triangle of Koch. So this is, the margins are formed by septal leaflet, inferior margin of coronary sinus, and tendon of Todaro. The AV node lies just in the middle of it. And one has to be very careful when the surgeon is doing tricuspid valve repair, replacement, whenever anything is going on here. Just because if suppose this is trapped during the suture or something, the patient will go into the AV dissociation or the heart block. So it is very important to know. And whenever we are doing any repairs, so case repair, we are putting the tricuspid annulus ring, we are doing the D Vegas repair, everything will go on like from this to this, and this place is left open so that we do not cause any conduction blocks. So this is the image where we've placed this tricuspid ring. So this is C-shaped, okay, and this C is open at the place where we've got this AV node. So this is my triangle of Koch, which is shown by the septate line with this indented lines with the dotted lines. Is tricuspid valve really tricuspid? Because, in autopsy, it was seen that many patients, they had only 2 leaflets, and the posterior leaflet had 2 scallops. Okay. And there was single leaflet in 6 hours, double in by Sunita et al. So they reported that tricuspid valve is really tricuspid because, a number of patients had bicuspid with one more indentation or scallops in the posterior one. Now, what are the different views to assess the tricuspid valve? Straight coming to the transesophageal echocardiography. What do we want to see? So I'll be discussing all the views one by one. So what will you see? Number of the leaflets, size, shape, thickness, mobility, calcification. How is the annulus? How is the subvalvular apparatus? And then we will be doing quantification by color Doppler. So these are major 4 views we'll be seeing. So this is first 4-chamber view, mid-esophageal 4-chamber view. We know this is RA, RV, LA, LV. Here is the tricuspid valve. Now, what is important is whenever we'll be going for the repairs, we should know what leaflet is seen in which view. So if this is a 4-chamber view, so this is the septal leaflet. And this may be anterior or posterior. Usually it is anterior. So this is a case of severe mitral stenosis. We can see the sac in the left atrium, and this has led to severe tricuspid regurgitation. This is what you can see in the 4-chamber view. See. So this is MS. We can see the piezo of MS and the back pressure changes presenting to us with severe tricuspid regurgitation. So this is severe secondary tricuspid regurgitation. Now, why is this annulus measurement important? So annulus measurement is generally done at the end diastole. We check it from the edge, from the insertion of the leaflet to the septal insertion. And 4-chamber is better because it is said that bicaval view a number of times gives a slightly higher kind of diameter. RV inflow outflow also gives you slightly higher kind of diameter just because we see it obliquely. So if suppose we have to plan for any intervention, it is good to go for 4-chamber view. And if this is more than 4 centimeters, or if I index it and after indexing it is more than 21, 22, then it calls for an intervention. Now this is RV inflow outflow view. If now the probe is turned, so this becomes the posterior leaflet. This is the posterior and this is the anterior or septal leaflet. See, this is the posterior and this is anterior or septal. So this is how we go. This is the RV inflow outflow view. So this is aortic valve in the center. This is left atrium. This is right atrium. This is the tricuspid valve. So this is the posterior leaflet. This may be anterior or septal. This is the RV. This is the RV OT. This is the pulmonary valve and this is PA. So RV inflow outflow view. This is a view where we have good evaluation of the tricuspid valve as well as the pulmonary valve. When do I call it modified? First we've got bicaval view. In the bicaval view, we have got SVC, IVC, LA and RA. So if suppose we can see the tricuspid valve here, so then it becomes a modified bicaval view. Okay. So this is SVC, IVC, RV, and this is the tricuspid valve. So this near the coronary sinus or IVC, this is the posterior leaflet. And just opposite to the posterior is the anterior leaflet. Now this view is very important just because in all other, the alignment for my continuous wave Doppler was not good. But modified bicaval view at the angle of say from 90 to 110 degrees, this is 105 degrees, we will get a very good alignment for continuous wave Doppler. So this is IVC, this is SVC, this is LA, this is RA, this is tricuspid valve, and this is the right ventricle seen at the angle of 113. So look at this jet. When I see it at modified bicaval view, look at this jet. And if I put my cursor here, it comes in line. So this is the view where I can have all my color Doppler, continuous wave Doppler, and all the derived values. So if there is TR, So how do we calculate? So this is how this TR jet is coming here in the RA. If the velocity is more than 2.8, means it is significant. How this dense continuous wave Doppler signal with a full envelope, this indicates severe TR. And the RVSP can also be calculated, which is like 4V max plus RAP. So if suppose from the fourth chamber, I withdraw a probe and now I want to see. So here I was like a bit confused if one is septal and it may be anterior or posterior. But if suppose this is a 5-chamber view, then we are very sure that this is the anterior leaflet and this is the septal leaflet. Transgastric RV inflow view, I think this is a very good view to look at the subvalvular structures for the tricuspid valve. This view shows us the RV wall, inferior wall, anterior wall, and the leaflets. I'm seeing from behind, so this is the posterior, and opposite to the posterior is the anterior leaflets. So we go make the transgastric view and turn the angle to 80 to 180 degrees. So transgastric basal short axis view. See, in all other views, we can see only the 2 leaflets of the tricuspid valve. So transgastric basal short axis view is the only view where I'll be able to see all the 3 leaflets. So my probe is here. So near the probe, I've got this posterior leaflet. Okay. Just opposite to the posterior, I've got this anterior leaflet. And near the septum is the septal leaflet. See. So near the probe, I've got this posterior leaflet. Here is the anterior leaflet and here is the septal leaflet. So we generally make it at, we go transgastric, turn the probe slightly towards right, increase the angle from 0 to 30 degrees. And here we can find the all the 3 cusps of the tricuspid valve. This is a CT image, just trying to correlate with the CT. So this was the 4-chamber view. So if I'm seeing from above, this is the anterior and this is the septal leaflet. Now in the B, this also shows the septal and the this is 2-chamber. So now this has been rotated. So septal and posterior. Now if this is showing the short axis of all the leaflets. So I don't know if you can see it clearly. So we have here you can see it clearly. So this is the septal leaflet, anteriorly is the anterior, and this is the posterior leaflet. So this is how we can see in MRI all the 3 leaflets of the tricuspid valve. So now beginning with the pathology, apart from tricuspid stenosis is also not so common, but then we do find tricuspid stenosis in rheumatic heart disease. It can be acquired, it can be congenital as well as iatrogenic. Now characteristic features of isolated tricuspid stenosis will be that there will be right atrial hypertrophy and distension, but our right ventricular function is preserved. So what are the echo findings? There will be thickening and distortion of tricuspid valve. There may be commissural fusion, especially in the cases of rheumatoid. Valve area is less than 1. And the gradient is generally, like if it is a severe TS, the gradients are 5, 6, 7, up to 10. And how do I calculate? Like in mitral valve, it is 220 upon PHT. Here it is 190 upon PHT. And the VTI is more than 60 centimeters. There is right atrial enlargement more than, if I think of area, it is more than 18 centimeters square. And IVC is more than 2.2 or 2.5 in cases of severe TS and TR. So common slight preponderance in females. And we know that peak inflow velocity through a tricuspid valve is less than 0.7. But if it goes beyond 1.5, then we have to think of stenosis. And here the gradients are lower than that of mitral stenosis. But anyway, anyhow, more than 2, it calls for your attention. So if suppose mean pressure gradient is more than 5, VTI more than 60, T half more than 190, valve area less than 1. These all are supportive of severe TS. Now coming to tricuspid regurgitation. Now tricuspid regurgitation can be primary as well as secondary. Primary is when it is affecting the cusp leaflets. And we do find this especially in the drug addicts. There may be infective endocarditis where we've got only tricuspid valve involvement just because they take all these IV drug abusers. They've been taking drugs through the and all the circulation goes to right side of heart. So isolated TR with infective endocarditis usually points at the drug addicts. There may be the pathology may be rheumatoid heart disease, carcinoid syndrome, myxomatous, endomyocardial fibrosis, congenital may have Epstein's anomaly, and there may be atrial fibrillation. And we have seen that because of the tricuspid valve, the pacemaker leads going through tricuspid valve, there may be changes because of that. Now coming to 2 3 very important pathologies, that is Epstein anomaly. Now identifying Epstein anomaly is very, very important. And we do have incidental findings. Patients may not at times there are different variants of Epstein anomaly. And we do have patients. 3 4 days back, we had a patient of severe AS, and the patient also had Epstein anomaly along with that, though it was a very low grade and it did not require much intervention. But we, how did we diagnose it? So the septal leaflet was apically placed, and the difference between the mitral annulus and the tricuspid valve annulus was more than 8, and there was good part of RV that was atrialized. The other is carcinoid tricuspid valve disease and rheumatic. So in carcinoid also, there will be thickening of the leaflets, but there is no commissural fusion. In rheumatoid, there is commissural fusion, and generally the associated mitral or aortic valves may also be involved. So this is a picture showing Epstein's anomaly. So the trick is, at a number of times you may not find, a very good regurgitant flow jet. So decrease the Nyquist limit a bit, because these are low flow areas. So decrease, and the cardiologists, they say ki identifying regurgitation in Epstein's at an early stage is an art. So you keep on decreasing till 40 and then try to, localize the jets of the tricuspid, whether the intervention is required or not. So this was what I was telling you, that this is basically the perimembranous part. So this is the mitral annulus and this is the tricuspid annulus. This distance is less than 8. If suppose this is more than 8, there is this septal leaflet goes down. Okay, this anterior leaflet, it becomes long. This septal becomes redundant. These all are characteristic features of Epstein's anomaly. There is one very important scoring system known as Seller Major or Goose scoring system, where what we do is we calculate the area of the right atrium and the atrialized RV, and we divide it by functional RV, that is left below the septal and the anterior cusp, plus left atrium plus left ventricle. If this combined area is less than 1, then only go for interventions. If it is like 1 to 1.5, you must weigh. But if it is more than 1.5, there is no point in enabling, because morbidity mortality is very high in these patients. So if suppose I have to address the tricuspid valve with respect to regurgitation, so there are few guidelines. How do you assess it qualitatively as well as quantitatively? Slow, I guess. Yeah. If we've got flail leaflets, and I've already discussed about this TR jet, about this IVC diameter. So go for the qualitative as well as quantitative assessments. So if IVC diameter is more than 2.5, RA area is more than 18 centimeters square. Now jet area inside the RA or the vena contracta is more than 7. If there is systolic flow reversal in the hepatic veins, there is triangular continuous wave dense and the velocity is more than 2.8. These all point towards severe TR. So apart from these qualitative, we should also look for the quantitative analysis. And I'll show you how we get this 3D, assessment of the tricuspid. There is 4 TVQ analysis, that is tricuspid valve analysis quantitatively, which we will do on 4D machine, and we will get all these values by AI. So if suppose it is a chronic TR by Doppler, so these are the criteria which I've already told you: dilated annulus, large central jet, more than 50% of the right atrium, vena contracta is more than 7 millimeters, P size like about 1. So dense triangular jet, all these point towards the, now Kaplan clearly says that tricuspid regurgitation, it does not have that subclinical or stage A. Whenever we see it, it is basically progressive functional or asymptomatic or symptomatic. Okay. So what is important is surgeon is already operating on the left side of heart. He wants you to tell them that whether they want to open RA or they want to look into this RV, go for a tricuspid valve repair or replacement. If it is a primary pathology of the leaflets are torn, then the valve replacement is considered. Otherwise, this is a low flow system. So tricuspid valve repair is what is needed most of the times, because a number of times it is functional. So these are additional echo measures that we see. Now, what are the recommendations on the primary? If suppose surgery is already undergoing and patient has got primary tricuspid regurgitation, so we have to do the tricuspid valve intervention. Patient was symptomatic with or without severe RV dysfunction, we should do the tricuspid valve intervention. So these are grade 1 recommendations. Okay. If the patient is having severe secondary tricuspid regurgitation and patient is already open for left-sided valve surgery, the patient must undergo this. And if there is if the annulus is dilated more than 4 or indexing more than 21, then also the patient must undergo the intervention. Now, there is a conundrum of tricuspid regurgitation. It is severe, but what more, at times it is massive. Massive means, I told you, when the effective regurgitant orifice area is more than 60 to 79. Regurgitant volume is more than 75. Okay. And VC is not 7, but it is 14 to 20. So then this is massive. The one higher grade is torrential. That is when your regurgitant volume is more than 75 and VC is more than 21. So imagine the right side of heart. So because this conundrum came into view just because, at times just decreasing the tricuspid regurgitation from torrential to massive to severe or to mild or moderate, it makes a difference. Even if the tricuspid regurgitation does not disappear altogether, but if it is decreased from this severity to even moderate, even then the quality of life in the post-operative patient period becomes better. So coming to the 3D analysis, as I've already told you, so we've got now tricuspid valve. Earlier, we could not see all the 3 leaflets, but now with the help of the 4D machines and AI, we do have this kind of analysis of the tricuspid valve, and this gives a very good perspective. And we can see through the right ventricle, we can see through the right atrium. So, and the other is its relation to the aortic valve. These are the few things that we need to know whenever we are projecting this 3D. Why 3D? Because it clearly depicts the number, coaptation gaps, and geometry, and especially when we are in this world of tear. What we do in tear is we bring this anterior and posterior close together so that the intensity of the tricuspid regurgitation decreases. This is done under general anesthesia nowadays. It is a 3D guidance. Okay. And we have to, prevent the patient from complications also. So knowing this anatomy and doing it continuously whenever this procedure is going on is very, very important. So this is the intraatrial septum, coronary sinus, this is the septal, this is the anterior, and this is the posterior leaflet. So again, the views, what is important is you should have good 2D views. You should know what kind of cusp is this. Just because, I told you that this is suppose this is 4-chamber view. So 4-chamber view, what is this? This is the septal leaflet. So I mark it, this is yellow. This is yellow, and I put a marker also, S to it. Okay. So I know that this can be anterior posterior, but when I see it RV inflow outflow view, then this is posterior. If this is posterior, now this is anterior and this is anterior. So yellow and green I've given to septal and posterior where I'm sure. And the third color is given to the anterior. So once I'm trying to, bring the 3D reconstruction. So this is how I'll get the same colors and I'll get the labeling. So this is how my 2D, evaluation and marking is very important. So when I was doing this marking, I also placed these. So I have done this from the RV side, that I place this marker below the septal. So this is my septal. Look at this. And believe me, it is not difficult. Means you just keep on doing it, practicing it, doing an OT, just marking it. You should know that, yes, this is, what is this? This is posterior. This is anterior. This is septal. So once I know my views, I have marked them properly. And once I generate a 3D image, this is how it comes. Now the next is, I put an en-pass view that I can, place. I have marked the aorta also, aortic valve also. So now the surgeon knows the correlation with the aorta also. This is again, I have reconstructed this tricuspid valve image in my OT. So this is flexi slice where I can see the image, and I've already marked 2 leaflets, and I just wanted to see the inlet view. There is another thing as 4V TVQ, that the monitor has got fully AI kind of thing. And we take a 4D view, and after having a 4D view, we do the alignments and the labeling. As I've already told you, they'll ask you to do the coaptation points, and they've already marked the images. And we take 2 good images where we've got explain. Like suppose I've taken 20 to 30 degrees for my 4-chamber view, then 110 degrees for bicaval view, and then I can have a very good image of tricuspid valve. So look at this. So once we've done this 4TVQ analysis, we'll get the worksheet where they will tell you what is the annulus area, annulus perimeter in the 4-chamber, in the 2-chamber, the major axis, the minor axis, means letting us know about all the details from the worksheet. Then we've got all these values. So look at this characteristic image of the saddle shape, the high points, the low points, the way tricuspid valve is moving, whether we require any intervention or not. So innovation calls innovation from left side to right side, from tower to tier. We've been growing and doing all these things. Like we were doing mitra clip, we've got the tier system here, we've got the Pascal, we've got coaptation devices, and now it's not only 2D, 3D, 4D. 4D, you've got real time calculations. This is how it differs from 3D. And then it has been seen that, correlates well with the cardiac MRI. So these are the different, techniques and steps where we are doing this clipping of anteposterior leaflets, the zipping kind of thing, which we do in tear, giving you all the details. This is the Pascal system, and this is how where I have imaged all the 3 leaflets in the transgastric view. So this is the D Vega's repair. This is the ASD. This is the D Vega's repair, where the surgeon, this was dilated, but after this repair, this has narrowed down, and we've kept this area open to prevent the conduction blocks. So after the tricuspid valve, I'll begin with the pulmonary valve. Pulmonary valve, they are difficult actually to echo image, and you need a lot of practice. To begin with the anatomy, the thin leaflets. Tricuspid, usually semilunar valve, located anterior and superior to the aortic valve, like I showed you in the first image. It consists of anterior, right, and left cusp. Each of these cusps is separated from one another by commissures. What is important is below the free margin, these cusps overlap, okay? And this overlap area is called lunula. At the central point, okay, there is a thickening called nodule of Arrhenius. And because of this, this closes very tightly. So this maximizes the closure. And like we've got aortic sinuses, we've got sinuses and pockets here in the pulmonary valve also. But the problem is it is difficult to, image because of its position between the alveoli and the pulmonary artery. Though over the years we've learned, but then, in the patient of congenital heart disease, imaging of right ventricular outflow tract of the pulmonary valve, this is very, very important. So the challenge is, yes, distance from the transducer TE, complex anatomy and morphology of the pulmonary valve and alveoli. Here also, we cannot see all the three leaflets simultaneously by 2D, but yes, 3D, it does help. And on OT table, it is the epicardial imaging that gives you the superior most results if the surgeon is looking for pulmonary valve corrections, aortic PA correction, RPA, LPA, then it is the epicardial imaging that goes a long way. So what do I want to assess? Like RVOT, we've got valvular structures, we've got supravalvular and the subvalvular structures. Now their leaflets, their motion, their integrity, if there is any mass there. Now 4 views for the pulmonary, that is mid-esophageal RV inflow outflow view, which I've already shown. Mid-esophageal aortic valve short axis view. Upper esophageal pulmonary valve long axis view or aortic arch short axis view. This is the view that we use for PDA, for seeing the PDA, patent ductus arteriosus, coming from the aorta to the PA. And this is the view where I'll be looking for the continuous wave Doppler, just because this is best aligned. And then we've got the transgastric view. Transgastric view is one of the best views for continuous wave Dopplers also, and for post repair, for seeing the pulmonary valve replacements, the gradients after the surgery. So these 4 views are very, very important with respect to TE in the case of pulmonary valve. I'll be dealing with them one by one. If I talk of transthoracic views, they are very, very easy to obtain. You take a Plax view, you rotate the probe 90 degrees, make it horizontal, and then you will have this aortic valve short axis kind of view where you can have the pulmonary valve in picture. And this is very easy to obtain because, pulmonary valve is just below this in the Plax view, and it is the anterior most. So in transthoracic view, it comes out to be very well. If I talk of transesophageal, then this is the aortic valve short axis view where I can have the PA and pulmonary valve. Then I've got RV inflow outflow view. This is how we place the probe, and this is how they're cutting the section to see the pulmonary valve. Now, upper esophageal pulmonary valve long axis or aortic arch short axis view. I think this video is not playing. So this is the first. We will focus on the descending aorta. We will withdraw the probe till we find the arch. Once we find the arch, we will keep on increasing the angle. So this arch becomes circular. This becomes a short axis. A slight tilt towards right will bring the PA in view. This is the pulmonary artery. And if suppose there is stenosis, you can see the turbulent jet over here. If suppose there is PDA, you will see the blue flow, right, coming from the aorta to the PA. So this is how we see. So this is the pulmonary valve. This is the pulmonary valve. The flow is from here, and this is the arch short axis. So this is CT scan image just showing the sinuses. So this is the cadaveric heart. So these are the sinuses. I just wanted to show you the sinuses of the pulmonary valve. Okay, and this is right, left, and anterior. These are 3 leaflets. So at times it can be bicuspid, it can be quadricuspid, it can be pentacuspid, and we have seen a number of times, like with TGA and with tetralogy, we do have bicuspid pulmonary valves. Now, pulmonary valve regurgitation. I think this is very, very common. Even in ASDs, we will have this mild pulmonary valve regurgitation. So it can be normal or pathological. When do I call it as normal? When there is a very narrow short jet, and you'll put a probe in all the ASDs, and you will find this a very small red flame coming just below your probe placement. Below is the aortic valve short axis, and above you will find this, and this is very common physiological functional negation generally seen in ASDs. When do I call it pathological? Pathological is when I've got pulmonary hypertension, I've got valvular outflow tract abnormalities. Then there is a white jet origin. Jet width is covering more than 60% of the right ventricular outflow tract. And there is color flow reversal in the pulmonary arteries. Now, how do I go? Evaluation of pulmonary valve, the RVOT morphology, the presence and severity of the pulmonary valve regurgitation. And it is because of the, complex RV geometry. And there may be, the patient may have undergone the previous surgery, maybe some palliative surgery because of the CHD, and now the patient is having pulmonary valve regurgitation. So for this, not only 2D, but then 3D, and um, whether there is coaptation of leaflets, where is the jet going, all this is very important whenever we've got secondary pathological pulmonary valve regurgitation. So this is how I define the degree of severity. This is taken from Kaplan. When the jet density is dense, vena contracta, generally we do not see all these things in pulmonary valve. But if suppose there is severe regurgitation, we may find all these things. And the color Doppler jet width is more than 50% of the RVOT width. Okay, the regurgitant fraction comes to be more than 60%, and there is a diastolic flow reversal in the pulmonary artery, which we usually do not see so easily. But then there is caval dilatation, IVC, SVC dilatation. So there are back pressure changes. This is what we see in the pulmonary valve regurgitation. I'll come to the management again. What about the stenosis? I think in congenital heart disease, even in adult, pediatric, all kinds of congenital heart disease associated ASD, VSD, we must always rule out pulmonary stenosis. And this affects normally 7% of the patients with congenital heart disease, and there is female preponderance. And this stenosis can be at 3 levels. It can be valvular, it can be subvalvular, it can be supravalvular. The pulmonary valve may be domed, it can be tricuspid, bicuspid, unicommissural, hypoplastic, or dysplastic. So I think transesophageal echocardiography gives you a very good diagnostic tool in knowing the level of the stenosis, the severity of the stenosis, and your guidance, how to go about managing this pulmonary valve regurgitation, whether the patient is the naive patient coming with CHD, has come post-operatively after repairs. Now, first of all are imaging. So first of all, obviously, we will go for the transthoracic views, having the pulmonary valve and RVOT tract. And then we can have all the quantitative analysis for the continuous wave Doppler, pulse wave Doppler to localize the site of obstruction. And now the color wave Doppler to visualize flow acceleration, narrowing, turbulence. And if, we all know that normal pulmonary velocity is like 1. If suppose it is more than 3 or 4, then it has to be a severe stenosis. Now, if this is, we are, projecting towards this stenosis, about this velocity, where am I seeing this? Whether it is subvalvular, or it is supravalvular, or it is at the level of valve. It is very important. And it is very important in the management also, in the pre-op medical management also, just because like in tetralogy, we have got this dynamic component as well as fixed component. So this valvular level is fixed, but this infundibular level is dynamic. So here, when you've got more of infundibular or the dynamic component, so these patients will they will respond to your beta blockers in the cases of cyanotic episodes. So knowing this subvalvular pulmonary stenosis is very, very important. And here we can measure the gradients also. I can see the velocity is growing up to 4. And in this image, you see that this is the supravalvular level. So knowing your intervention management, so if I do something here, is it going to help the patient? No. So knowing all these things is very, very important. So muscular and infundibular obstruction, it is also frequently characterized by late peaking systolic jet, and it also appears as a dagger shaped. And if it is jet velocity is more than 4, peak gradient is more than 64, this is how I grade it as severe pulmonary valve stenosis. What are the interventions that we do? We've got balloon pulmonary valvuloplasty. I think a number of patients coming with this. We in the cath lab we've got a number of patients undergoing balloon pulmonary valvuloplasty, and if they are not fit for it, we do go for surgical valvotomy. And if the pulmonary valve is severely deranged, having severe PR, then we do go for pulmonary valve replacements. So this is the procedure for pulmonary balloon valvuloplasty. We go to the transfemoral route, and then we must follow up once we've relieved this, because this will again come back. The patients, you have to do the regular echocardiographic follow-up, just because they may come up again with PS or PR. So in tetralogy of valve repairs also, patients, they come for after the repair, they come with severe pulmonary regurgitation. So that leads to right ventricular dilatation. They have arrhythmias, they have impaired exercise tolerance, they've got TR. So we do have to address with surgical valve replacement after them. These are small views showing this is like this is VSD, and this is the pulmonary valve in the aortic valve short axis. This is the so this was ascending aorta short axis. So this is a patient after the repair. So they've done the repair, and they've placed a monocusp over here. It's just, I don't know why this is not running. Yeah. So we have to see how much is the regurgitation after the repair. So yes, this is one of the most important, and I think one of my favorite views whenever I am assessing the post-tetralogy repairs. The surgeon has already placed this monocuspid pulmonary valve. See how beautifully we can see this. You go to transgastric views, and then you change the angle, focus towards the right side. You can see the RVOT gradients, the pulmonary regurgitation through this newly placed valve. So nowadays, even after post-tetralogy repair, they're not leaving the patients for free PR. They are placing this monocusp. So this is long axing. So this is what I was telling you, that this was, we were trying to see PDA, and this is the pulmonary artery, and this is the aortic valve. So whenever they are generally 90 degrees placed, so whenever you've got ascending aorta, I've made this arch as short axis. So once it is in short axis, the pulmonary artery comes in the long axis. So if I would have opened it a little bit, I would have all the gradients here. So this was trying to acquire the 3D. So we see once I was trying to image, I made this view for RV inflow outflow view, and then I was trying to focus this with the X-plane, and I could see that this pulmonary valve is bicuspid. So this was a case of tetralogy, so I could see this. So whenever these patients, they've been operated with, they may or may not have been operated, but with the severe PR, these patients, they're coming in later stages, and with 3D we are able to, even with 2D, we are doing percutaneous pulmonary valve implantation to prevent this severe PR. So this is again the transgastric view, and here I can see the pulmonary valve beautifully in these patients. This is again aortic valve short axis view, the way the flow is going through the PA. Having aortic valve and the pulmonary valve both in one picture at the angle of 40 degrees. In the cases of ASDs, we do find bigger tricuspid valve. So another delayed complication, endocarditis, though it has not been reported well, but then this after interventions, this is something that disturbs us in the post-operative period a number of times. Pulmonary valve endocarditis, and now just to conclude, that transthoracic echocardiography, it remains the first line imaging modality for assessment of etiology, mechanism, severity of tricuspid, as well as pulmonary valve disease, impact on right heart structures and functions. Comprehensive assessment, knowing the etiology, pathology, first making 2D views, then making 3D views, seeing the back pressure changes, imaging. If you have doubt, go for cardiac MRI, go for CT scan, try to correlate. And then, because having these congenital heart disease repaired and then coming back later in disease for the residual defects, we need to have good idea of all these pathologies, though it is a challenge. But then yes, this is the way to go. Thank you, sir.
Thank you. Thank you, Dr.
Thank
Rachna,
you.
for. Yes, Durga, please.
Thank you, ma'am, for the wonderful presentation as always. Tricuspid and pulmonary valves are little difficult to
Tricky.
image, and uh, for the surgeons also, our TE decision making matters. Whether it is Ross procedure or whether to go ahead with the TB repair are the only two questions they have.
No, I
So,
I just missed on this. How can I do that? So, for the for my postgraduates and DM candidates, uh, Ross procedure is then the patients, they generally present with the aortic valve pathology. Okay, and at a very young age, say 10 years, 12 years, 13 years, 14 years, 16 years, though it can be done at the higher age. I do not want to put a prosthetic valve. So if suppose this pulmonary valve is good, if there is concordance of PA size and aortic size, the surgeons, they what they do is they put a graft on the pulmonary valve as normal, but then they implant this pulmonary valve into the aortic valve, so that there is one native valve. And why is this important? Just because the child will grow, the LVOT will grow, so that this native tissue will also grow. And this won't, though they do come with stenosis, but then Ross procedure is basically designed for them. So if suppose if the surgeon is planning for Ross procedure, then having this 2D and 3D evaluation of pulmonary valve, having this PA annulus, PA size, and this pulmonary valve being tricuspid, no leaflet abnormalities. Giving all these details to surgeon is very, very important. And this is what we do, obviously, in the adults and not in pediatrics. And we are happy doing it, just because our 4D machine, the 4D probe, is good for adults and not for pediatric. So if we've got the weight is more than 20 kgs, so we've got this probe, and then we can very well do, we can do this assessment very well. And Ross procedure is where we put in the pulmonary valve in view of the aortic valve, and there we put a conduit. This is how we go about this. What is important is not only putting this, we have to reimplant the coronaries also. So that is a bit tricky, and we do it at early age, so that when the child grows, LVOT grows, the native tissue also grows. Thank you, Dr. Durga, for and having this insight into Ross also.
thank you.
There's a lot of appreciation for your talk, and I really congratulate
I can't see
you.
anything. Thank you, sir.
It is in the chat box. There is appreciation for your talk. Well done. You are very calm and comprehensive, clear presentation with good
I could
images.
not show the videos. If I have time, I can. I've made videos, means how to come to that 4D analysis. But then
Sure,
see.
sure, sure. If there are any questions from comments from the participants, please do so. We have, I'll give 5 minutes because it's an important subject. So we'll close at 10:05. Any questions or comments? Please feel free.
Good morning, sir. Arup here.
Hi,
Arup,
Arup.
yes, come on.
Hi, Rachna. Very nice presentation. The images of the tricuspid, 3D, and pulmonary valve monocost was really impressive. So, I mean, because you mentioned about the percutaneous pulmonary valve replacement,
Yeah,
just
yeah.
a few days back, maybe a month back, we
Mhm.
had a DOF repair patient who had a free peer
Yeah.
came presented with the adult in an adult age, and then we took the patient for a percutaneous pulmonary valve replacement with a TAVI valve. But there is
Yeah,
some
yeah, we have been
there is
doing that.
some complications with that procedure, and then emergency pulmonary valvotomy we had to do at the mid of the night with a
Need to have hybrid OT, and you keep your OT
yeah
free and ready and immediate transfers if suppose you're not having hybrid OT.
yeah because
Then
the annulus is so much dilated. We did an MRI, we checked everything, but somehow the TAVI valve uh, it was not fixed very well. That's why we replaced with a mitral valve, tissue mitral valve in the pulmonary
we are
position.
also doing that. We are doing the surgical replacement if suppose the pulmonary is too much dilated. It is good to take this post-op repair for we've been putting these mechanical valves only because
Yeah.
these patients they come generally at the age of 13, 14, 15, 16, 18.
Mm.
So for them having that free PR and this RV dilatation and arrhythmias, and they do come after one episode of at least TIA or some one episode of collapse. So I think
Mhm.
it is good to intervene early so that we decrease this PR for their longevity. This is what best we can do, I think so.
Yes.
But, in my cath lab, they are doing this. Uh, and we do have complications, but then we generally prepared for TAVI, though everyone is doing, I think, freely, but then we do have complications everywhere in complex
Mhm.
patients. You're right.
Actually, a problem with the imaging of the pulmonary and tricuspid valve with 3D is that with a normal valve, when the leaflets are very thin and pliable, the 3D imaging will be very difficult. I mean, and not difficult. I mean, the great images will not be there. But if as the leaflets thicken with pathology, then obviously 3D becomes more and more beautiful. Then the images you get are brilliant.
So if the beginners are trying to do this, I'm telling you, I this is what I tell my students. So try to image these valves in patient of ASD. In
Yeah,
ASD, the tricuspid valve is beautifully seen. The pulmonary valve is also beautifully seen. So try to learn your imaging from those patients of ASD. Okay, and then gradually you can pick up. So
absolutely. Yeah.
yeah, because it is very difficult in the cases of PS. But then just because, and then the surgeons they are putting in that monocuspid holograph also, so we have to see all those images in post-operative period. So I think we've been practicing it, and this is how my students have also learned it, and obviously we are also doing it.
Excellent.
Yeah.
Yeah,
Dr.
yeah. Such a tip to
Yes,
learn
Dr.
the
Dev.
pulmonary valves in ASD patients. Very nicely pointed out. Yes.
Yes, sir.
Any other comment?
Rachna, can I?
Good morning,
Yes.
ma'am. How are you?
Very nice presentation. Thoroughly hooked.
Oh, ma'am, this is what
Thoroughly
we've
hooked.
been doing. Bas, that's it.
Okay, please, let us know when it is too late to address TR. I mean, there one should not do anything. I mean, very late.
The patient, RV, see, if it is sole TR, now we have to see whether it is associated. If it is like associated with RV dilatation, RA dilatation, the liver is all congested. You see the backflow changes. If the patient is in frank failure, though they say that it is not like that you do not intervene, but then they do say that if it is like massive or torrential, decreasing it is a bit better. But then how does the patient body respond to it? I don't, ma'am, if you have some specific concern, then please do let us know
No,
also.
no, no, no. No. Suppose we are not in the intraoperative scenario, patient is otherwise uh, not intraoperative scenario. This is not. But when TAPSE is less than 10 or fix
Yes,
pulmonary
that's what I'm saying, ma'am. RV
hypertension,
dilatation or
and then
RV functions are very low.
renal and hepatic functions are also deranged. One should, I mean, they are doing lot of these things
Uh,
using
can, can
transcatheter.
I add something here? Can I add something here?
Yes, sir, definitely, sir.
There is what is called a strict valve system, which is a minimally invasive percutaneous transcatheter solution for severe tricuspid regurgitation where they are not fit for surgical procedures or any other intervention. What they do is they put self-expanding biological valves in the IVC and the SVC. Two valves they put, and this is called trick system. It decreases the systemic congestion because of the tricuspid regurgitation, and the liver functions, kidney functions improve. But the tricuspid valve regurgitation remains. But I'm told that there is functional improvement in these patients because you are reducing the systemic back pressure effects of TR. This is
Yes.
what is we have done few cases here with satisfactory results.
Yes, sir. Absolutely. I second you, sir. We recently got one patient with a for heart transplant, DCM, torrential TR. The general
Yeah,
condition was so bad, so much venous congestion. So you also put a trick valve to reduce the severity of the tear affecting the liver, so that
yes,
liver gets better and general condition improves, and then we can post her for a heart transplant. So
right.
symptomatic relief to protect the liver, kind of shielding. This one.
Yes, yes. Actually, you put two competent valves in the
Yes, sir.
one in the SVC, one in the IVC,
Yes,
so
sir.
that TR does not affect the systemic organs.
Absolutely, sir.
Nice, nice.
Right.
And we did one pulmonary valvotomy for bicuspid valve 2-3 days back. And in
Oh,
transthoracic, beautifully we could see, bicuspid opened up. Otherwise, it's very difficult to see.
And the transthoracic is like very good
Very
for
nicely.
pulmonary. For all these infective endocarditis in post-operative period, we do all the transthoracic only.
Very nicely seen. She had PFO also, which was the cause, elderly woman, cause for some desaturation, which was improved after this.
Okay.
thank you so much. I think it's time to wind up. I would like to thank Dr. Rachna for that excellent
Thank
presentation.
you,
Very
sir. It
well
was
done.
honor and pleasure being here.
It was very well done. It was you took through all the nitty-gritties and you also give some tips here and they're very nicely done. Thank you so much. I would like to thank you personally and on behalf of all the organizations under which we are doing this educational program. Thank you so much. I would like to thank Dr. Divya and Durga for being with us, Dr. Sanjeevani and Arupratan for their valuable inputs, and all the others who have participated. And we have tagged usually a case presentation. I think the case presentation is not there today. And it being IACTA Con 2026 next week, we will not be having any session next week. So we'll see you on the 8th of March. And with that, I would conclude this session and thank you for your presence. And I request Swastika to play the IACTA TEE 2026, the video. Thank you so much.
Sure, sir. So thank you
Thank you.
to all.
Yes.
Thank you so much to all the dignitaries present here. Client is really glad to have all these brilliant people together in session today. And I really hope that you all had a seamless experience. So with everyone's permission, I'm concluding the session in here for today and looking forward to host you again. Thank you so much, everyone.
Thank you.
Thank you.
Thank you.
Thank you. Have a good day.